Thank you to those who have submitted questions in advance of the meeting. We'll answer as many of those as we can, and we'll take further questions after all of the presentations. At that point, at the end of the meeting, if you've got a question for the governing body, which you haven't already submitted, or if you think of something you would like to ask as we take you through this morning's presentations, please use the chat function to post it, or you can raise your hand. I won't be responding to questions until the end of the meeting, as we're working on a strict timeline to make sure we do have time for questions at the end. And also, just to say, we're not able to answer questions about an individual's care or cases, but if you've got concerns, then please use the usual routes to contact us. We might not have time at the end to answer all the questions, but we'll try and group them so that we can answer as many of the most important issues as possible. So let me now take you briefly through our agenda this morning. So we're going to start with Sarah, our accountable officer, and she's just going to, Sarah is going to take you through an overview of the last year, and then we're going to review the South West London response to the COVID-19 pandemic. So I'm going to talk to you about clinical leadership through the pandemic. Nicola is then going to talk about the primary care response to the pandemic. You'll hear from Dino about support for care homes, particularly focusing on Sutton. And then you'll hear from Nhs and Vasa about the recovery programme, so the recovery of planned care activity and how we've managed that after wave one. Next slide, please. After that, Agnella is going to talk about the COVID-19 vaccine programme. And then you'll hear from Melissa on our approach to equality, diversity and inclusion in the South West London CCG. James will then cover finances, and then Sarah's going to do a bit of a look ahead to what we can expect over the coming year and going forward. And then at the end, questions from the public, and then I will close the meeting on time. So without further ado, let me hand over to our accountable officer, Sarah Blow, and let's move on to the next slide.
Thank you, Andrew. Do you want to move to the next slide, please? So I've been asked to give an overview of the year. It's been an extraordinary year, hasn't it, for not just for the NHS, but internationally, but particularly in the NHS. And when I was asked to do 8 minutes on what we've achieved in the last 12 months, that was the impossible task. And you're going to hear loads of really good news stories about how we've adapted and how we've worked together across the NHS and across local authorities and our partners to actually deliver services during the pandemic. So I will leave that to others to go into the detail, but I thought what I would actually do is pick out a few of the things that we have done in South West London. And it is only a few, because I would like to be able to talk to you about all of the work that's gone on across South West London, but that's not going to be possible in the time that we have. So firstly, I would say that we at South West London responded well in setting up our incident control room and helping to facilitate all of the discussions across the system to make sure that we were all coordinated. And that's been an important part. We often hear about our frontline services, rightly so, but there was a lot of work going on in the background with our teams, making sure that people had access to PPE, making sure that drugs were available, making sure that the services across the system were coordinated. And I'd also like to thank them for the work that they've done behind the scenes, as well as the work of our frontline services. But talking about our frontline services, I think I'll just pick on a couple of areas. So the first one is primary care. We're going to talk a little bit more in detail when Nicola talks about the response from primary care. But I know there's a lot of stuff in the media at the moment saying about GPs not offering face-to-face appointments. And I just wanted to clear up that we are very proud of the response in South West London that our GPs have had, both during the pandemic and as we start to recover from the pandemic. And GPs across South West London have been seeing patients face-to-face throughout this period. And actually from March through to today, they have over half of their appointments are actually face-to-face. So people can get access to face-to-face appointments in South West London. And we've actually got some really, really positive patient survey results for our local practices, some of the best in London. So that was one of the areas I wanted to highlight. The other area that I wanted to highlight was elective recovery. So we have set up 15 clinical networks, and Andrew will talk about that later. But overall, we responded really well through our acute trusts to the pandemic while it was happening. But not only that, they have continued to deliver elective care to local people, and they have delivered way over the previous amount of elective care that we were delivering during the pandemic. So although we had a halt on elective care, since the beginning of the year, we have reduced the number of people waiting over a year for an operation by over 80%. So our clinical networks are really focusing on those areas of needs, and our acute hospitals are responding really positively to what we need to do going forwards into recovery. Do you want to go to the next slide? So I just wanted to highlight as well that addressing health inequalities, and particularly the death of George Floyd in the United States, has highlighted to us issues around Black Lives Matter and the movement that came out of that. And it became particularly clear to us in South West London and across the country during our COVID vaccination program that there were a number of people that weren't accessing services or weren't getting access to services that we needed to make sure that they received. And the COVID vaccination program had over 250 virtual engagement events with local clinicians reaching out to people in the local population to give them really good information and facts about the vaccinations, and allowing them to ask questions and to really, for us to increase the volume of people that were willing to take a vaccination. And we've been really successful in South West London in that. And I know Agnello will talk about that in a bit more detail later. Improving healthcare together, we made the decision last year to move ahead with the building of a brand new specialist emergency care hospital for Epsom St Helier being built in Sutton. We're really pleased that this model of care, which we believe will be really beneficial for local patients, is starting to move ahead. And the Trust is now working on the full business case and is working with the national team and the Treasury to make sure that we can build our future hospitals together. I also just wanted to mention the issue around organisational change. We have actually merged 6 CCGs and we are now transitioning towards an ICS. But what I would like to highlight is not the change, but actually how we have kept business as usual going throughout that change. And we have ensured that although organisational change happens, and it happens for good reasons, and that we get better outcomes for patients through the process, but actually that we continue to deliver services and to deliver any changes that we need to do in order to get benefits for local people. And actually the CCG oversight framework for 1920 achieved a good rating from the national team and from the regional team. So it's a positive news for South West London CCG. Can we go to the next slide? So I just wanted to finally say thank you. Everybody was clapping for the NHS when the pandemic started. I'm so proud to have been part of the response to the pandemic, but mainly I'm in awe of our frontline clinicians and those that work on the front line and support them to deliver what has been the most incredible response through the pandemic over the last 18 months. And so I would just like to say my own personal big thank you to all of those people involved. Andrew.
Thank you, Sarah. So, could we just take the presentation down, because I'm not going to use my slides. I could definitely talk for more than 8 minutes on clinical leadership, which is what I've been asked to cover at the start of our focus on how we've responded to COVID. As chair of the organisation, I would say that there could have been no more difficult time to launch a new organisation that is responsible for making sure that healthcare in South West London meets the needs of our population. There can't have been a more difficult time to do it than the start of the global pandemic. At the same time, there can be no better people to have done it with than we have in the South West London CCG. No better people to deal with the level of adversity that we've had to deal with, and no better people to ensure that we deliver the best possible care for people in South West London. We've got people with experience, with knowledge, with cool heads, and with a real passion for what they do, and that was incredibly important in the response to COVID. I'm focusing here on clinical leadership, but I needed to start by talking about all the people who work for the South West London CCG. One of the real strengths of clinical commissioning and a legacy that we must preserve is clinicians and managers working together as a single team alongside each other, and that has been incredibly successful and important during the last year. In South West London, we've invested quite a bit since the inception of CCGs in clinical leadership, particularly in GP leadership. We've done a huge amount of work to find clinical leaders, to support them and develop them. And honestly, coming into the pandemic, that gave us an incredible foundation. Boy, did we need that clinical leadership as we responded to the pandemic. As the clinical chair of the CCG and the chair of the South West London Clinical Senate, I was asked at the beginning of COVID to set up a clinical cell, which was bringing kind of key clinical leaders together in South West London to meet and agree clinical strategy, how we maintain safe services in South West London, to provide mutual support between senior leaders in our different organisations, and to share learning and best practice. And we did that around issues like infection control and testing for COVID. The other thing we did was we linked into London work. So myself and Nhs, who was my kind of co-lead in South West London before she moved on to other things and was the medical director at Croydon, we attended the London Clinical Advisory Group, where we agreed London-wide clinical guidance and approach to service changes and movement of patients and facilities around the capital to ensure continued care for people across the city. In our South West London Clinical Cell, which over time became our clinical leadership group in South West London, we focused particularly at the beginning on maintaining frontline acute services and critical care services for people with severe COVID, but also ensuring the safety and protection of non-COVID patients and keeping those essential services running. After we'd got out of wave one of the pandemic, there was a real shift to focus on recovery. So building back and getting restarted services for people who hadn't been referred during wave one of COVID and during the national lockdown and who hadn't had treatment. And making sure that we got services up and running again. And more recently, we've had a real focus on vaccination as well, which has been incredibly important, and we've delivered really well in South West London. CCGs have a real history of providing GP leadership. The challenge in creating the clinical cell was what we needed was multi-professional leadership across multiple different organisations. And we involved medical directors and nursing directors from acute hospitals, from mental health trusts, and from community services. We had a director of public health, we had an allied health professional lead, we had infection control specialists, and we had a lead paramedic from London and Ambulance Service. And that just created more diversity and a much better, broader, richer perspective on some of the issues we were tackling. And it's becoming an incredibly cohesive group. And those senior leaders we've been able to put into some of the other cells that have been doing really important work across South West London, and to support various groups to make sure that we had clinicians supporting good decision making across South West London. As part of the response to the pandemic, we had to change a lot of services really quite quickly. And drawing on the experience of years of clinical commissioning, we set up a service change review group in South West London that was reporting to the clinical cell. And that looked at all the different changes that were made in response to COVID, be that moving services, changing services so that they were more focused on telephone and video interactions with patients. We looked at all those to make sure they were safe and effective and that we managed any risks. You're going to hear later from Nicola Jones, who's going to talk to you about the clinical leadership of primary care, and she led the primary care cell in South West London and did that incredibly well. You're going to hear from Dino, who's going to talk to you about the approach to supporting care homes with a particular focus on Sutton. And I guess that brings me to just mention our boroughs. I've talked about, South West London clinical leadership, but so much of what we delivered was done through our boroughs. We've had strong clinical leadership in each of those places, and our borough teams have worked really well with local partners, particularly with local authorities, in making sure we deliver safe care for patients during COVID, particularly focused as well on supporting patients who might be shielding and those who live in care homes. The final part of what we did, I think, that I'd like to talk about is the recovery. So you're going to hear more about that later, but the recovery of elective services and dealing with the backlog on the waiting list. What we've done to respond to that is to set up clinical networks in South West London, and they focus on individual specialties like gynecology, urology, orthopedics. And they've looked at the whole group of patients that we have waiting across South West London and have gone through a really rigorous process of clinically prioritising those patients and making sure those with the greatest need get seen first. And I think that was a really important approach that needed strong clinical leadership. From the very beginning, our clinical networks were set up to look at the end-to-end pathway for patients, from pre-contact with GP right through to follow-up at the end of treatment, not just the little bit that happens while the patient is in hospital. And our networks have therefore been much more effective about ensuring we deliver effective and efficient care for patients. To do that, I was able to call on really experienced primary care leaders to come and lead those networks jointly with hospital leads. And you're going to hear specifically from Nhs and Vasa later, who have been two of those leads who have helped lead the clinical networks. The networks have been so successful, they're really owned by the South West London system now. They've become the model for London and for elsewhere. And because of the impact of our clinical networks, we're the best performing sector in London on a lot of the elective recovery work. And I think that a lot of that is down to the strong clinical leadership. So what we definitely have demonstrated over the last 18 months is the value of multi-professional leadership in South West London. I know that no one in the system would dispute that. CCGs are going to cease to exist in April 22. Sarah's going to talk to you about that later. So the CCGs will cease to exist, but clinical leadership will not. We've got a really strong platform in South West London, and I know that the integrated care system, the ICS, is committed to continue to support multi-professional leadership and to further develop and strengthen that at every level in South West London, and that should be incredibly reassuring. Right, that's at the end of my section. So if we could bring the slides back up, I'm going to hand straight over to Nicola Jones, who's going to talk about the primary care response to the pandemic.
Thank you, Andrew. Can you just go to the next slide, please? My first slide. Thank you. Well, good morning, everybody. I'm delighted to be talking to you about primary care today. As Sarah mentioned, it's a topic that's attracting a lot of attention currently. And that's not surprising, given its pivotal role in the NHS. General practice deals with 90% of patient interactions in our NHS, and therefore it's important to all of us. And given that so much of our healthcare happens in primary care, I think it makes it all the more remarkable how in March 2020, at the start of the pandemic, in spite of dealing with volumes of patients, practices made such rapid changes to ways of working when it was asked of them. Many practices had to survive with a very depleted workforce at times as team members came down with COVID. And it was very important at that stage to ensure that practice premises didn't become an unsafe place for patients and staff. So waiting rooms in most practices were not designed to deal with a pandemic. So patients were kept safe by separating patients with COVID from those with other conditions. And in some cases, patients were seen on different sites depending on whether they had symptoms of COVID in order that they could be seen safely. So practices worked together to organise this. To reduce the spread of infection, staff wore protective equipment, masks, aprons, gloves. And remember, this was very alien at that time, although we're all much more used to it now. Patients were assessed and managed remotely in order to ensure that COVID didn't spread to vulnerable people in healthcare premises. Video consultations were used, in addition to telephone consultations, to triage people, to determine what the right course of action was and whether a face-to-face assessment was then needed. And that was challenging and unfamiliar for professionals and for patients whose relationships and interactions are usually based around an in-the-room consultation. So we learned to use new technology. We innovated, we put in place new processes, and we educated our people to work in different ways. We also learned about a whole new medical condition, the understanding of which was evolving in front of our eyes, and we had guidance and instructions pouring into our practices every day. We learned to use online meetings to get professional and peer support for colleagues that were desperate for it as we all battled to do our best for each other and our patients in this really strange, uncertain new world. In general practice, we lost colleagues and family and friends and patients, and it touched every one of us. And I'm proud of the health and care professionals in South West London who gave their all. Next slide, please. So in mounting our pandemic response, practice teams focused on people who are the most vulnerable in our communities. We identified people who needed more support and those who might have serious consequences if they were to get COVID infection. We had close to 1,000 people who live with a learning disability, and they had a health check, giving them extra time with their GP to make sure their needs were being met. We used our practice data to identify people with long-term conditions, for example, those living with diabetes, serious mental illness, and other important and life-affecting conditions. And many of these people were shielding, so we provided care in whatever ways were most acceptable to them. Some were afraid to attend the surgery, so we did our best with telephone and video, and many people have chosen to continue to access care in those ways whenever it's possible because they now feel more familiar with it. We were concerned that some people might be reluctant to seek care or unable to do so using the new digital means. We knew some patients were preferring not to attend their practice due to infection risk, and we understood that people might perceive that it wasn't possible to get advice. So we ran a campaign called the Nhs Is Open, and that was to raise awareness of when people should come forward and ask for advice. We wanted to make sure, as the pandemic eased, that people with important symptoms knew they could seek help. General practice was also a huge support to the wider system, especially during the peaks of the COVID waves. Practices opened on bank holidays to ensure that emergency services weren't overwhelmed at that busy time, and our practices collaborated to provide thousands of additional appointments in hubs around South West London to assist when 111 and our emergency departments were dealing with high numbers of people. Next slide, please. For people who had coronavirus infection, we used new approaches to make sure that they didn't need to go to hospital unnecessarily. Pulse oximeters were deployed by practices to monitor people at home. Low blood oxygen levels are a marker of severity in COVID infection, and these quite nifty little devices were used to pick up this danger sign early. In Wandsworth, where I'm a GP, we're coordinated across our 40 practices to provide a taxi service to take the monitors to people who were self-isolating, and this helped people manage their illness more confidently at home, reduced anxiety, let clinicians manage more people more safely, and it prevented hospital attendance where it wasn't needed. Next slide, please. And then during the autumn in 2020, GPs delivered the flu vaccination program, and along with community pharmacies, practices vaccinated 70% of the target population, which included for the first time everyone over the age of 50. Now, we deliver the flu vaccine program every year, but this was in very challenging circumstances and to more people. And then came the COVID vaccine. And I won't dwell on this because we're going to hear more from Agnello Fernandez soon, but I'm clinical lead for the programme, and I set up and I'm still running a vaccine clinic for my local practices. So I can't resist talking about it. And within 6 weeks last winter, we mounted the most ambitious vaccination programme ever seen. Practices worked together and they set up vaccine centres in practices, church halls, community venues in every borough. Staff worked through Christmas, New Year, weekends. We trained an army of vaccinators and we were supported by fantastic volunteers and our local CCG staff in a brilliant team effort. And general practice delivered 70% of this country's vaccines. By April, we'd vaccinated 600,000 people in South West London. And that was in addition to delivering all the other general practice services in a constantly changing environment. So this has been an extraordinary response to COVID-19 from primary care, and I am hugely grateful for GPs and their teams and the CCG staff across South West London for their commitment and resilience during really what's been the most difficult time that we've ever faced. Thank you. Back to you, Andrew.
Thank you so much, Nicola. Let's go on to Dr. Dino Pardinani, who is going to talk to us about support to care homes.
Thank you, Chair, and good morning, everyone. I'm going to be talking about the South West London approach to supporting care homes. Next slide, please. We value the commitment care homes across South West London have taken with us in providing the safest possible services for the most vulnerable people in our community. And we've worked closer than ever supporting our partners in the care sector across South West London through the pandemic, particularly on infection prevention control. Additional measures to support care home staff and residents have included having a nominated GP lead, ensuring that all care homes were supported by a primary care with a weekly check-in with multidisciplinary team support, that all care homes have access to pharmacy support, and that they're all aligned to a primary care network. Ongoing nursing and therapy support to care homes for older people was also provided through the InReach and therapy teams, alongside wider support from dietitians and speech therapists. Our behaviour and challenging communication team has been supporting staff in care homes to care for the residents who are experiencing behavioural and emotional difficulties associated with mental health diagnosis and or dementia. The team also provided mental health and wellbeing support to staff in care homes during the pandemic. South West London formed a new infection prevention support team to support care homes to answer queries related to infection prevention control, to share best practice tools, and to offer training and support where gaps were identified, or where there was an outbreak in a home, for example. And training was supplemented by weekly infection prevention and control webinars for all health and care providers in South West London. Regarding personal protective equipment, so PPE, a mutual aid process helped care homes and other organisations that were having difficulty sourcing PPE. Over the last year, we provided telehealth kits to nursing homes and are also working with care homes and clinical leads across South West London on a wider rollout to care homes for mental health patients and people with learning disabilities this year. We supported care homes in South West London to begin using NHS Mail, which accelerated discharge processes for patients coming out from hospital and back to their care homes. We introduced the e-Red Bag initiative, which saw documents being sent electronically by care homes to acute hospitals when residents are transferred by ambulance across South West London this year. These documents are linked to personal records, allowing a smoother and safer handover of care between providers. We provided training to care home staff on spotting the soft signs of deterioration in residents, and we've worked with care homes to make sure that they're using the NHS England capacity reporting system. And so a London-wide view of bed capacity supports the faster hospital discharge and reduced admission programmes. An example of this collaborative working I've just highlighted is in action is shown on the next slide, which highlights the Sutton context, where for over 5 years the Sutton Health and Care system has built a strong partnership, and so this laid a very good foundation to provide oversight and support to care homes within Sutton from the start of the pandemic. Sutton has a total of 78 care homes, 43 of which for people with learning disabilities, and our support to care homes was adapted to meet the needs of staff working in LD learning disability homes, using bespoke sessions and targeted additional support, including making available learning disability specialist nurses. Sutton system leaders established a fortnightly meeting of the bed-based board, bringing senior leaders, including clinical lead for care homes, together to ensure take-up of infection control training, allocation of funds to enable homes to improve infection prevention control, and to enable homes to increase staffing capacity. To help us make sense of how best to respond, we developed the what's called the alert response plan process. So teams were trained to be alert to the information that was shared about the different challenges being experienced by homes, and use other sources of information to help develop an understanding of issues, including take-up of training, staff sickness, infection rates, for example. And depending on the findings, we determined how and how best to respond. Themes were collated along with the required response and included in the care home support plans. The key achievements are highlighted on the slide deck, and the speech bubbles, I think, give a nice context of the comments that we received from our care home providers regarding this approach that was taken. The next slide highlights how we cared for vulnerable patients out of hospital. During the second wave of COVID, the main challenge to patient flow through South West London hospitals was the availability of appropriate beds. As the number of COVID-19 patients being admitted increased, the infection prevention and distancing measures restricted bed availability. So we also saw an increase in numbers of patients being readmitted and more patients having to stay in hospital for longer periods of time, over 14 days, in both intensive care and on general wards. So we responded to these challenges by commissioning additional high intensity rehabilitation beds and reintroducing continuing healthcare assessments and teams to support discharge. Regarding moving COVID positive patients to dedicated care homes during the pandemic with COVID-19, patients with COVID-19, but those who no longer needed hospital care, they were transferred to dedicated care homes, and they're called temporary alternative discharge destinations. They're called TADs for short. They're to complete a patient's period of isolation. So these TADs provided a setting where patients could continue their recovery before going to their own home or care home. Working with nursing home staff and the Central London community healthcare provider CLCH, Merton GPs and all borough social care colleagues helped to establish and support 2 TADs. And the next slide, please, shows how we've protected staff and residents. This year, we've prioritised supporting care homes in South West London by providing comprehensive training packages, webinars and networking and support sessions. During the first wave of the pandemic, we offered all care homes in the area training for working safely, including training for donning and doffing protective and personal equipment and basic hand decontamination through our team of super trainers and trainers. During the second wave of COVID, we developed an infection prevention control training package that was tailored specifically working safely in care homes and offered this training to all our 366 care homes in South West London. Regarding safeguarding this year, the pandemic and the lockdowns have also seen an increase, unfortunately, in violence and abuse. We work closely with our partners in policing, education, care, and local authority departments to risk assess and protect the most vulnerable children and adults. We've increased the work of our joint intelligence groups to highlight any safety and safeguarding concerns in our care homes during the pandemic. Regarding testing, by the end of April 21, testing had been extended to care homes and home testing kits were made available for staff. And finally, regarding the vaccination program, we've heard a bit about that. The care home staff were, of course, in the first group of cohorts to be eligible for vaccination, and we worked with local authorities to identify staff and invite them for vaccination. The South West London CCG Staff Insight Survey showed that many care home staff, compared to the national average, had reservations about vaccinations. And so the slide indicates how we addressed that. And that was through working with local authorities to reach and engage staff to answer questions, working with PCN teams who were able to vaccinate within the care homes themselves, and also using content from staff themselves posted on social media to encourage others. Thank you for listening. Back to you, Andrew.
Thank you so much, Dino. And I think listening to that and Nicola's presentation, the amount of change that people have had to put in place in primary care and community services is quite remarkable, and the amount of work people have done to support patients is really, really impressive. So from out of hospital, though, to more in hospital, we're going to go on to Nhs and Vasa, who between you are going to talk about recovery.
Yeah, thank you, Andrew. Good morning, everyone. First of all, what I'm going to do is talk about the recovery program, and then we'll hand over to Vasa, who will give you a case study about what this meant in reality. So if we can come to the first slide, please. Many patients throughout following wave 1 were waiting for elective surgery. Now, this was for a variety of different reasons, mainly around staff sickness, staff redeployment into the ICU and onto the wards, and also with infection prevention control measures actually impacted on the number of patients that could be seen for surgery and also for diagnostics. There were cancellations of procedures, and also some patients weren't coming forward with symptoms that they did have. The recovery program was led initially by 6 clinical networks. This expanded to 15. As Andrew has said, they were jointly owned with primary and secondary care, but also included clinicians across mental health, nursing, allied health professionals, community providers, medicines management as well. And they created shared learning and standardization across the different approaches, and making sure that they enabled the hospitals to work much closer together to manage those patients whose operations had been put on hold and needed it most urgently. It did focus on the whole patient journey and coordinated patient care across the different settings. The clinical networks have actually centralized some of the operations to try and make sure there's efficiencies in the system, freeing up staff and resources at other hospitals so they can continue to respond to the COVID-19 pandemic. Could you go to the next slide, please? So with regards to the increase in planned surgery, the way that we did it was actually setting up dedicated surgical hubs in a variety of different specialities, including orthopedics, ophthalmology, urology, etc. Now, this enabled, for example, Swellyock to actually increase their throughput by 125 patients per month because they'd expanded capacity to include an additional theatre. And the Swellyock is the actual elective orthopedic centre over at Epsom. For example, ophthalmology at Moorfields, based at St George's and Epsom St Helier, increased the number of cataract operations to around 800 operations each month. And all 4 hospitals did continue to offer cataract surgery as well. So urology in October 2020 was centralised onto the Epsom St Helier site as a pilot for a urology hub, mainly for Epsom St Helier and St George's patients. And again, going on to the hub aspect, general surgery was centralised onto the Croydon site and the Kingston Hospital site, offering support for those patients waiting longer for care at St George's. So as you can see, there was a theme going here whereby hospitals were coming together to actually try and share patients. They were using day surgery wherever appropriate. And by November last year, all 4 acute hospitals were able to carry out 90% of planned surgical care procedures that would have been done the same time the previous year. So the latest position on planned care is at the moment on the 52-week waits. South West London trusts are ahead of the plan and clearing the backlog that we had at the end of June. Planned care, also the trusts have achieved the required Elective Recovery Fund performance, and South West London was the 2nd highest performing sector in London against the 2-week wait for cancer patients. I'm going to hand over to Vasa now, who's going to give you a case study in urology. There you go, Vasa.
Thank you, Nhs. Yes, Nhs, we saw a waiting list. It was a challenge, but we saw no numbers, but we saw people. So our response was to see what can we do for our patients on the waiting list, be it for surgery or be it for outpatient appointments. And we came up with a plan. Our plan was informed by our patient focus groups, which I'll come to you, which is in the next slide. But all what we did was based on what they told us we should be doing. So before COVID came along, if you had a urological problem, what service which is offered to you, be in hospital or be in primary care, could at times vary depending on whom you saw and where you lived. We wanted to change that, and we did. By developing South West London pathways, we were able to agree on preferred treatment choice and clinical investigations and even medications. What took years for us to agree in pre-COVID days, we achieved in a few months. The spirit of the ICS was born long before the legislation as far as all these clinical networks are concerned. Formulary harmonization, which I have heard about for more than 25 years, for urology, is a reality now. Dedicated surgical hubs born out of necessity gave us an opportunity to provide efficient and standardized care. Working as one across South West London rather than as 6 boroughs and 5 hospitals, supporting each other, the concept of mutual aid is here to stay. Yet another example of ICS function predating legislation. We in urology now treat it as a long-term condition, not as a surgical entity confined to hospital care. Our pathways promote self-care, care in primary care, care by community services, care in hospital, But self-care is at the heart of what we do throughout the pathway. Andrew has talked a lot about clinical leadership. Clinical leadership is what enabled all this to happen. Hospital community-based clinicians working as one, as a pair, leading a network, supported by managers from all the boroughs and from all the hospitals, nurse specialists, pharmacists. Everybody was involved in our meetings, and we meet every week. It's a non-hierarchical concept of a meeting, and we are also institutionally agnostic in every single discussion. We do not think of where we come from and who we are, but we think about South West London and our patients. At this point, Ben, Dam, and I, the clinical leads, really have to thank our managers, because if not for them, this would not have happened. Our managers were not working in the buildings they normally meet us face to face. They're working from home. And despite all that, they were able to engage with us and be the platform on which the urology network built whatever we have done in the last 18 months. Next slide, please. I would also thank the comms team, because despite their heavy focus, appropriately so, on vaccines, they were able to organize not one, but 3 meetings for us with our patients. So we met with patients who have suffered the burden of disease, be it recurrent UTI, be it low urinary tract symptoms, or people who have unfortunately have long-term use of catheter. We were consistently told across these 3 working groups when we met our patients that they wanted early investigations, they want early interventions, they want a lot of self-care throughout the pathway, and they wanted a rapid response when they ran into complications. In addition to clinical suggestions, they also told us about attitudes. They told us in our educational webinars, we should convey to clinicians that at times we might accidentally imply promiscuity. At times we forget that a trans person may be attending a gynecology clinic or a urology clinic, but may still have a prostate in the gynecology clinic. So these type of information, which we clinicians at times might forget, our patient group told us, please remind these clinicians at your webinars to be careful in what we say and how we act. The most important lesson, Andrew, for me was at one of these webinars when I began my introduction by saying that I've been a clinician for 30 years, only to be informed, quite appropriately so, by one of the people in the panel to say that they have had a catheter in them for 30 years. At that point, we all knew who the expert was. So, Andrew, the confidence we gained by these patient interactive sessions we ran has now enabled the urology network to consider community-based urology clinics in non-healthcare settings. And if you are kind enough to invite us back next year, I can talk to you about a urology clinic in Pollard's Hill Baptist Church. Thank you, Andrew.
Thank you so much, Vasa, and that's really inspiring, and I think just embodies the principles of what we've been trying to achieve as a clinical commissioning group. So thank you so much for sharing some of those examples as well, and thank you, Nhs, too. Right, on to Agnello. You're going to talk to us about COVID vaccination.
Thank you, Andrew, and good morning, everyone. So we've already heard this has been a year like no other. From the start of the COVID vaccination program on the 8th of December 2020 to March 2021, over 600,000 vaccinations were administered to more than 500,000 people in South West London. That's now risen to well over 2 million across South West London. GP practices, pharmacy teams, hospital and CCG staff have been at the centre of the COVID-19 vaccination programme as we continue to inform and engage and protect more of our local people into 2021. Croydon University Hospital and St George's were amongst UK's first vaccination hubs, and Croydon University Hospital safely secured its place in history by vaccinating one of the first people in the world against COVID-19 on Tuesday, the 8th of December 2020. GP practices in South West London work together in 39 primary care networks to deliver the vaccine programme to people in the community from 25 dedicated vaccination sites across the patch, in GP practices, in community settings like local health centres, in churches, and community halls, and not to forget the over 300 care homes across South West London to help vaccinate our vulnerable elderly population. During February and March 2021, we opened 9 South West London community vaccination centres in venues not normally associated with health and care, like sports stadiums and shopping centres. These new sites played a key role in helping us to vaccinate eligible residents alongside health and care staff, and included the Battersea Arts Centre, Selhurst Park, and the Harlequin Stoop Stadium. We also continue to hold a number of pop-up clinics in mosques, in temples, in churches, and community centres to help us reach further into those communities with the lowest uptake. Next slide, please. So listening to and engaging with different communities has been crucial in reaching people whom we might otherwise not come into contact with. It's been important to be able to answer people's questions and address their concerns. Since last December, we've held over 250 virtual engagement events across South West London, involving our local clinicians and reaching over 8,000 local people on face-to-face on virtual meetings. Our initial insight from local people told us we needed to build confidence and trust in the vaccine, particularly amongst people from some of our Black and Asian and minority ethnic communities, including Black Caribbean, Black African, Bangladeshi and Pakistani, and some of our Eastern European communities. Our South West London CCG engagement team worked with our clinicians and key community and voluntary sector groups at borough level to help inform people in areas where uptake was low, to reassure them and that the safety of the vaccination, and to dispel the myths that circulate even to this day on social media. In each borough, we developed a bespoke engagement plan with our council, our voluntary sector partners, to engage with communities with lower uptake and use the vaccine data to inform where we would locate pop-up vaccination clinics and focus our activity. We also funded the voluntary sector to reach deep into communities, to engage with different groups and have conversations and inform people about the vaccine. Huge amount of work has taken place. Next slide, please. Just as an example of how we worked and are still working together in Croydon with the Croydon BME Forum and the Asian Resource Centre and other borough partners to hold community conversations to give local people the opportunity to put their questions to a panel of experts that included Dr. Nhs Is Open, the former medical director of Croydon University Hospital, and Rachel Flowers, Director of Public Health in Croydon, and myself. We've held numerous targeted engagement sessions, including with care home staff, domiciliary staff, and Age UK personal independent coordinators and the Healthy Living team. We've appeared in Christian churches services and in mosques on Islamic television, reaching over 30,000 populations. We've addressed people in temples and in other religious settings. As a result, we saw many people from the groups that were more reluctant and concerned about vaccinated in the early days to come forward and receive their vaccination. And the conversation continues. For those who have not yet taken up the offer, we have an evergreen offer so they can present themselves at any time to be vaccinated. So finally, in years to come, when our children, when we're older and greyer, and our children and our children's children ask us, what did we do in the great COVID-19 pandemic? We can hold our heads up high and say that coming together as clinicians, as managers, as administrators, and an army of volunteers, we made a difference and we had success to protect our communities with the COVID vaccination program. Thank you, Andrew.
Thank you, Agnello, and what a really powerful way to finish that section. I know just how much work has gone on across South West London on vaccination, and I know the work that you've done in Croydon has been really impressive. The incredible support from the communication and engagement team that we've got at South West London has been really remarkable. So I did want to call that out. Let's go straight on to Melissa. Melissa's going to talk to us about equality, diversity and inclusion.
Morning, everyone. So I think my piece segues quite nicely on from the last section you just heard. So I'm Melissa Berry, I'm the Programme Director for Diversity, Equality and Inclusion. And over the last year, I'd say from July last year, when I joined the organiser at the CCG, it was at a time where we'd had Black Lives Matters. We knew more of our staff, Black and ethnic minority staff, were impacted by COVID-19. And so we had a real focus as an organisation as what we were going to do in terms of working with our workforce. And by working with our workforce, it betters the work that we do with our patients. So we started with running a series of focus groups. So all staff across the CCG were invited to take part in the focus groups. If you can move my slide, please. We're invited to take part in the focus groups. And we held 16 focus groups across the course of an 8-week period. We then went on to hold focus groups with managers, the SLT and more senior leaders in the organisation. So from those focus groups, it was apparent that lots of things were coming out about changes that we might need to make in the organisation. And where the CCGs had merged together, they'd probably had less support around equality and diversity and inclusion that you might see in a provider. So we heard lots of things that came out of those sessions around our culture and our leadership, around development and recruitment, and really taking a stance and approach around anti-racism. So lots of organisations over the last 12 months have talked about anti-racism and really moving the programme on from just being around talk and really trying to take action. So you can see on this is just a snapshot of the things that came out of those listening events that we ran with staff. If you can move my slide again, please. And so from those listening events, we came up with 4 key themes that we would work on as the organisation. So we all signed up to those principles, and the action plan that we came up with was co-designed and then approved by the governing body. So the 4 key themes that we have been working on over the past 12 months are around recruitment, development, education and leadership. And what I'll do is I'll just talk you through some of the key highlights from each of those. So in terms of from the recruitment process, so we have something called the Workforce Race Equality Standard in the NHS, which looks at the indicators for Black and ethnic minority staff. So we had a big focus on recruitment and looking at who we're bringing into the organisation, but also how we're promoting an internal staff. So making sure that our panels were diverse from a gender balance, but also with Black and ethnic minority staff. So all the panels 8B and above over the last 12 months have been diverse, and we've seen improvements. So on that last year, we know from our 1920 data, you were 1.8 times more likely to get the job if you were white than if you were Black or ethnic minority. We have now reduced that to 1.3, and our ambition is that over the next 12 months there will be no difference. And really looking at our recruitment process and planning it from beginning to end. And then thinking about the development of our staff and giving them and making sure that they have the right skills to do their jobs. So looking at our appraisal policies, developing mentoring programs, and really kind of communicating all the development offer that we have in one place. And then turning our eyes to thinking about education and what that means. So a lot of from last year, I think what that did for equality and diversity is it really opened the doors to have conversations that we probably hadn't had as an organisation. And if we had them, we kind of were just going over the surface. So really normalising conversations around race, what that means, and anti-racism, doing allyship awareness, having courageous conversations. So really being able to think about ourselves as commissioners, but also how we are inclusive leaders. So we've done a lot of that work over the 12 months. What I will say is there's still much work to do. This work is never ending and also always evolving. And then turning to culture and leadership, really thinking about one of the things that I do is I have a regular drop-in session on once a month on a Wednesday morning for staff to come and raise concerns, but also talk about the good things that are going on within the organisation, and really keep on making sure that we're always listening to our staff, and then setting ourselves a key priority around becoming an anti-racist organisation and being able to normalise those conversations around race. We've developed a workforce report as well, so we can know who's in our organisation, what do we look like, what is our makeup. And then we have also, Gloria is now Gloria who's on the call is the lead with Charlotte for EDI but across the ICS and the CCG. So if you can move on to the next slide. And so the things that we've done, so I talked about, we developed staff to sit on panels, we developed a training budget, there are allyship resources on the intranet for staff to access. And regular feedback, so regular feedback that we feed up to the SMT and through the governing body, and then really also going out and celebrating our staff. So we've had LGBT History Month event, International Women's Day, we had a Black History Month event, and really also recognising all of the religious holidays or around Sickle Cell Awareness Month. So really trying to give our staff as much information as possible on this equality and diversity journey. And then I think it's my last slide, if you can move on to that, please. And then our next step, so we are in the process of having active bystander training, and that's a scenario-based training where we'll be working with staff about scenarios that we've experienced in the organisation and how we might progress on those in the future, and a reciprocal mentoring programme, and that will be for the CCG but across the whole of the ICS, and that will be about creating change, equity, people within the system, so that we can really take a look at how we move our equality and diversity award work together collectively, and also our gender pay gap review. And there are so many other things that are also happening across the organisation, and it's really a changing landscape. And so I think the last things that I will say is that we've really been on a journey over the last 12 months to embed equality and diversity in everything that we do. And it's really easy for people to say those words, but really learning about what it means to be an ally and an anti-racist organisation so that we can work better for our patients. So I'll stop there and thank you.
Thank you so much, Melissa. I mean, you brought huge energy and passion to the role, and it's been a real pleasure to work with you. So thank you for covering that. Let's go on to James, who is going to give us a financial summary. James, you're on mute at the moment.
Apologies. There's always one of us. Sorry. I'll just give a summary of the financial sort of environment for last year and just where we spent the money, and just trying to highlight how things sort of changed last year, because clearly with everything that you've heard, you can imagine that had quite a direct impact on the way we managed the finances. So if we just flick onto the first slide. Last year, the CCG overall budget was £2.6 billion for South West London. That slide shows you broadly where we spent the money. So more than half of that went into hospital care, with the balance going into areas such as community services, continuing care and primary care. And as we know, the CCG itself doesn't actually provide services, it pays for other services, but that gives you a feel for where the money gets spent that we received, and it was 2.6 billion last year. So on to the next slide. So as you've heard from all the previous conversations around vaccinations and the pandemic response, etc., there was quite a shift in the way that we had to manage money last year. The CCG was working under a level 4 sort of measure, which meant there was much more central sort of control around how the money flowed through. So a lot of the sort of more business as usual things around commissioning and contracts between CCG and provider were effectively suspended, and we were working to some mandated sort of areas on or numbers on that. Additionally, we had other things like there was management of sort of the PPE contracts was done nationally, and obviously we saw some big changes around the discharges from hospitals and the way that got paid. So there was a lot of upheaval, more central control and a bit less freedom. But what that did enable us to do was to make sure that the money we did receive got targeted to the most needy areas in terms of that response and all the things that you've heard about in the previous sessions. The one thing we were keen on was we obviously had to review our governance process, because clearly we didn't want money to be a barrier when it was doing what was very quick responses to emerging situations, but equally we had to have some sort of robust governance process to make sure that what we were approving and what we were spending was value for money and the right sort of areas to spend. And I think it's credit to the organisation and all the organisations in South West London that we've been able to demonstrate through last year exactly where that money has been spent and the decision making process that's gone through, without actually in hindering any of the important work that you've heard about. In terms of numbers, the CCG itself spent about 81 million around additional on COVID, additional expenditure, a lot of which went into the hospital discharge programme, but we did also spend additional money around primary care in terms of capacity and some IT and some of the things that you heard Nicola talking about, as well as investment into remote working and support of stay-at-home home models. There was additional money that went through the CCG direct to the trusts, and they used that money to effectively help their response around what they had to do around IPC and transport and all those other things. So that money went direct through to the trust. So next slide, please. Also heard from Agnello around the vaccinations. The vaccinations was a national pot, but I thought it was just interesting just to put the money out there. So that didn't go through the CCG's book, so it was managed separately through a national process. But you can see there the amount of money that got spent through to July 21 to sort of support that programme across South West London. Again, all that expenditure has gone through, been audited and gone through the national process, but it does give you a flavour for the level of investment that went into that, but also I think what it shows is that it hasn't impinged on the rest of our services. It's been kept as a separate pot, which obviously hasn't affected anything else that we try to do. And on vaccination, we're now obviously getting ready for the winter and the flu vaccination programme, and also the booster programme. So again, that process is ongoing, and that will be managed through the winter as well. Final slide, please. In all of that, we still have to produce a set of accounts, which we did, and we still have to produce an audited sort of set of accounts and hit our financial targets. Those are our 4 key financial targets. So maintaining financial stability, which effectively means breaking even, which we managed to do within our resources. Value for money test. We hit our mental health investment standard, which means that we spent the right amount of money, or the expected amount of money, on mental health investments. And also we have a running cost target, which again we stayed within for last year. So despite all that upheaval and the changes, we managed to hit all our financial targets. The next step, which I think probably Sarah's going to come on to in a minute, but the next step for us over the next 12-18 months is, as we start to get back into normal and we start to transition into an ICS, is managing the finances through that sort of next tricky 12, 18 months to make sure that we keep ourselves in the healthy position that we've had in recent years. And as I say, the CCG balanced and the whole system balanced as well across South West London. So all good. And I'll hand back to you, Andrew, on that.
Thank you very much, James. And that was a really helpful overview of the financial position from last year, and just incredibly well done to manage the money and balance the books, because there was so much change and movement of money and new funding moving around in the system that year. And I just think you and the team did incredibly well to oversee that and make sure we spent it appropriately. So thank you. Sarah, back to you for a look ahead.
Thank you, Andrew. Can we do the next slide? So I just realised that we're vaccinating so quickly that my slide is already out of date. We have actually vaccinated over 2 million people in South West London, so that's really positive so far. But we carry on. And last week we started to vaccinate 12 to 15-year-olds in schools, and we did 4 schools in Croydon, and Croydon Health supported delivery of that. And we are also working with Hounslow Richmond Community Trust to deliver the school vaccination program in the rest of South West London. So that will be happening over the next few weeks, and we hope to have almost 90% of our schools covered by half term. So that's a really positive piece of work that is happening now. But also GPs are still vaccinating, and they're vaccinating those that are high risk, that are young people, but also they continue to offer the vaccination to both those that require a booster and also for those that have not yet had a vaccination. We have what they call an evergreen offer. So if there is anyone on this call that has not yet had their vaccination, you can still access a vaccination in South West London. So please do, because we are trying to support us all getting back into some kind of normality in this country. The booster programme has started, and I have to say that my very elderly father went to Central in Croydon yesterday and received his booster. He said it was a fantastic service and he was well looked after. So that was really, really good. And we're currently still delivering around 10,000 jabs a week. So not only are we doing the COVID vaccinations, but we're also now starting flu vaccinations. So flu vaccinations are now running for the over 50s, and those are being delivered both through the general practice sites, but also through local pharmacies, and people can now start to access their flu jabs going forwards. Can we go to the next slide, please? So we're also looking at how we get business back as to usual, because we talked a lot about how we've responded to the pandemic, but we also recognise that there's still a huge amount of work to get us back to where we were and to improve on the position that we had around things like waiting lists. So we know that we are reducing those waiting lists at the moment, but there's a huge amount more work to do, and that will not be delivered overnight. We recognise that coming through into the winter this year, we still have COVID in the system. We still have winter pressures, particularly within general practice and our hospitals. But also we need to deliver more elective care than we ever have done in the past. Now, we are currently high performing in South West London in comparison to other parts of London, but we will need to really focus on what more we can do together. And the acute trusts across South West London are working together to make sure that we can maintain our elective capacity throughout the winter period. We also need to look at mental health and ensuring that we see people that have not actually been picked up by services for quite some time. And we know that we've had a recent 15% increase in referrals to our mental health services. And we want to make sure that we have the capacity to support those people, but also look at introducing a more integrated approach to children and young people. And we've actually set up a South West London Children, Young People, Maternity and Children, Young People and Maternity Board. And that's bringing together all of the specialised services and the specialists from across the system to ensure that we have the best services possible in South West London. And we talked about equality, diversity and inclusion. We are setting up a system-wide board for that at South West London level. And we're looking at existing good practice. We're doing a baseline assessment of what's currently going on across the system. And we're looking at how we can improve services and our approach for South West London. And we're also continuing to support our staff, and that's supporting our staff in the front line, and we have tried to make sure that staff received a break over the summer period, but we also are trying to listen to staff within the CCG who have been working from home in many cases, but also supporting the response to the pandemic. And we've had our own staff survey back, and we have created a number of actions across the organisation to support staff and enable them to have the right skills and the support to come back into the office, but also to continue to work flexibly from home and ensure that they are prepared and ready to move with the system as it moves towards an ICS. So we're doing things like we have a health and wellbeing network, which is developing health and wellbeing annual priorities, such as our staff charter. Can we go to the next slide? So I just wanted to talk a little bit about the ICS, because from the 1st of April, subject to the actual legislation going through, and we are expecting that to happen, South West London will become an ICS. And just to be clear, because I think somebody said, what's the point of an ICS and will it help us? The focus for ICSs is more about bringing together partnerships and collaborations across the system for the benefits of local people. So we've up to now had very much a commissioning provider split in the NHS, and this is about bringing together all of our partners into one place to make decisions that will help us to develop better services for local people. And the main role of the ICS is to improve outcomes in population health and healthcare. It's to tackle inequalities in outcomes, experience and access, to enhance productivity and value for money, and to help the NHS to support the broader social and economic developments that are required. And for South West London, our ICS is made up of 3 parts. We talk about our ICS places, which for us is the 6 local authority borough level services and people. Our ICS provider collaboratives, and we have 3 in South West London. We have a mental health provider collaborative, an acute provider collaborative, and a cancer alliance, and they all work together to improve services for patients. And then we have our South West London ICS, which is made up of an integrated care board and a partnership, where we bring together people from across the system to decide on what are our big priorities for health improvement over the coming years. We have a good example of where we came together as a system in South West London over the last couple of years, which is children, young people, mental health. And what we know is if we work together, we absolutely can deliver better outcomes for people. And that work, I know Andrew can talk about this much more than I, because he was the lead for this. But, you know, we listened to young people. We listened to the system and the people that work with those young people, such as families and schools, and we produced a whole school approach. But by setting a priority around children, young people, mental health for South West London that included all of our partners, we are starting to see some of the benefits of that coming through. And that was particularly the case during the pandemic, when we already had services available to young people that they could access. So I'm happy to talk more about that, but we were working with the whole of the system to develop our new ICS for South West London, and we're currently just looking at listening exercises and talking to people locally to make sure that we get this right. The most important thing for us as we go forward is ensuring that organisational change does not become the focus, but actually the benefits that it can produce is the focus of what we do. So that will be our focus for the coming year and the years ahead. I was going to stop there, Andrew.
Thank you so much, Sarah. Thank you to all our presenters, and thank you to attendees for listening to our presentations. So I'm now going to open the floor for questions, and I'm going to be the compere. We've received some questions in advance. Some of you might want to post questions in the chat, and others of you may prefer to raise your hand by clicking on the 3rd icon from the top left or top right in my case, I think, of your screen. So the face and hand icon, if you click on that, it puts your hand up. For me, it's just a hand, and if you click on that, I will be able to see your hand raised. So what we're going to do is I'll take one of the questions received in advance first, then I'm going to take a question from the chat, and then I'll see if there's a raised hand, and I'll take one of those, and I'll keep cycling between those three modalities. I'll have colleagues who'll be looking at the questions in the chat, and they'll be theming them where it makes sense to do that, so we can cover as much as we can. And we'll respond to all the questions that we've received in advance in writing, but we won't be able to respond in writing to all the questions that we get today in the chat or verbally. So I hope that makes sense. I'm going to start then with a written question, as I said I would. We had a lot of really good written questions, actually. The first question I'm going to take is from Councillor Jennifer Gould, Liberal Democrat from Cannon Hill Ward. And the question is, Merton has more people diagnosed with dementia than the London average, with 1,700 diagnosed. And with the demand set to rise following COVID, what more could be done to improve care in the community for dementia sufferers and their carers? So, Vasa, as Borough Chair for Merton, would you like to take that question?
Thank you, Andrew. Yes, I'm grateful for this question. As a GP who is working in a part of Merton with very high prevalence of both frailty and dementia, it's a question which I have often thought about. One of the lessons we learned during COVID, especially with the vaccine campaign in particular, that we learned that we have to always start answering these questions from the perspective of the patient and their carers. So what happened in Merton was that we had the Merton Dementia Alliance, which we are a part of. The Alliance surveyed patients who have dementia or their families on the impact of dementia. And what we learned from this lesson is there are three or four things we could actually focus on. One, expanding the number of dementia friends. Two, increasing the number of welfare checks done by dementia advisors. Three, engaging Alliance members to promote activities locally, in patient level or in community to combat loneliness. Increasing the number of Alliance membership, especially trying to focus to recruit more Alliance members from the Black and minority ethnic communities and faith groups, so that we support our patients in the community better, because we can come up with all the pathways under the sun possible, but the personal touch, the personal contact, the sensory input, we can't overstate the importance of all these things. And that is why the challenge to deal with dementia in the community is to work with the clinical sector, with the acute sector, with the community, with the volunteers, with families and carers, and exactly what we are going to do in Merton. But we mustn't also forget hospital care. Especially, we must appreciate how destabilizing an hospital admission is for people who suffer with dementia. And then there we are working with our partners, looking into sensory rooms in hospital, staff training, explaining to staff how the dementia and the illness impacts together. It's a double jeopardy when you enter hospital with a urinary tract infection or pneumonia on top of your dementia, which is already quite burdensome to you. So these are the things we are doing and we will focus on, so that people with dementia certainly don't need to suffer, but can be looked after kindly. And the key word here, Andrew, is kindness. There is no limit to the amount of kindness we can offer to support people when they are in hospital or in the community with the burden of dementia.
Thank you so much, Vasa. So I'm going to turn to our Director of Communication and Engagement, Charlotte, who is going to feed me a question from the chat.
So yes, Andrew, lots of lively questions and comments in the chat. So a bit of a summary. So positive comments about the Nhs Is Open campaign and the urology work that Vasa talked about, and perhaps learning for this for the rest of the system, Alzheimer's as an example. We've had two questions so far, one about the ICS, which we can come back to because I think Sarah's answered a bit of that, and the second one really is from Malik. So Malik is welcoming the recognition of health inequalities and the Black Lives Matter issues as a priority, but asking about our whole system approach. So what are we doing to make sure we support diverse and multicultural communities?
Thank you, Charlotte. So probably best to go to Gloria, our Director of Nursing, because Gloria, you're leading work on health inequalities in South West London. Do you want to come in to respond to that? Haven't got Gloria. Is Gloria on? I know you muted, Gloria. You can see Gloria's in the room. Shall I? Who should I then pass that question to?
Should we do the ICS one and then come back to Gloria, because I know she'll want to talk about that. So the ICS
be the best person to answer it. So let's hold it and make sure we get Gloria in to answer it. So give me another one, Charlotte.
The other one. So John Hallmark is, so Sarah's talked about, the ICS system and the bigger picture, but John is really asking, what will this mean practically for our patients on a kind of day-to-day basis?
Okay, so we've already started some of this change, is what I would say, and what I would hope you would see is an improved interconnection between some of our services and us working together as systems in a better way. What we're not going to see is a revolution in what we're doing. It will be an evolution of the work that we've done, and it's actually come together really well over the pandemic. So the elective recovery is a really good example. We now look across the whole of South West London to work out how you can access services as quickly as possible, not necessarily in your local hospital trust, but maybe in another hospital trust or another site, but you will still get a very high quality service. And sometimes with things like the South West London Elective Orthopaedic Centre, a better service than you might have got if it hadn't been consolidated onto that site. So there are real options for us as an NHS to work together. There's also real options around how we work together across South West London. And I gave the example of children, young people, mental health. But I was in a meeting yesterday where the Director of Public Health at Sutton suggested that there might be more that we could do together on air quality. So if we all worked together, and there are real benefits of us working together as institutions on things like workforce with our local authorities and with the local community. So it's those kind of areas where I would expect us to start to see the benefits.
Thank you, Sarah. So I don't think there are any hands up. I'm just checking there aren't hands up that I can't see on my screen, but I don't think there are. I don't think anyone's been bold enough to put themselves onto the main screen yet by putting their hand up. So let's go back to one of the written questions. Another question sent in advance from Miss Brito, local resident, and she has asked, are there any eligibility criteria when you call for an ambulance? Obviously that's a really important issue for this winter. Jonathan, would you like to respond to that?
Yes, thanks Andrew, and you're right, it is a really important issue given how busy we know ambulance services are at this point in time, and ambulance services obviously need to get to and treat the sickest patients in the most timely way. So London Ambulance Service, who provide ambulance care across the capital, including to South West London, they do triage calls on the basis of clinical urgency, as you would expect. So people, for example, who have a cardiac or respiratory arrest would be in the most urgent category, and you would normally expect an ambulance to be with those people within 7 minutes. Less urgent cases, you would perhaps also expect they will wait longer than that amount of time, and there may be a need to talk to a clinician before an ambulance is dispatched. What I've used this also as an opportunity to remind everyone on the call about the new initiative that's been put in place over the last year, the Think 111 First initiative, where every hour of every day patients can access through 111 urgent care. And that service books people into the right care pathway for them, be that self-care arrangements, be that booking slots in primary care, be it pharmacy or general practice, be that same day emergency care and getting people to see the right specialist in hospital or into the emergency department. So I would encourage people to think about the 111 First initiative, particularly given how busy ambulance services will be this winter, and keep the 999 number as free as possible for those with genuine emergency needs and the most vulnerable. Thank you very much, Andrew.
Thanks, Jonathan. So, Charlotte, back to you. Feed me another question from the chat.
So I think we'll just go back to Malik's question, because I think Gloria has now managed to connect. So just again, Gloria, so Malik was recognising the emphasis on health inequalities and the Black Lives Matter issues, and asking us about our whole system approach to make sure that we support diverse and multicultural communities, and also recognising Agnello's work in Croydon, I think.
Thank you. And my name is Gloria Roland, and I'm the chief nurse at the Nhs CCG. I'm one of the exec committee, one of the exec group. What I want to say is that there's a lot of work that's been done in this space, and I know Melissa have actually spoken a lot about some of the work we are doing with our staff. But what we want to do is to also look at some of the work we want to do with the communities within Southwest London. And I joined the exec team in January, and one of the things I've been asked to look at in collaboration with Charlotte is actually look at how we can improve the work we are doing around EDI and health inequalities. And what we've done is that we've actually sort of like established an EDI board where we want to look at what are the key issues in Southwest London and how we can support other local communities, voluntary organizations that are doing a lot of work in this space. And I know there's been a lot of work that's been done around this in Southwest London. But what we are doing is to bring all that together and then prioritize what are the key things that we need to look at within those areas. And one thing that maybe might not be visible is that there's also a lot of national call in this area. I know Public Health England have asked us to look at our 20 most deprived communities within Southwest London. What are the key health needs within those communities and how we can start sort of like pushing that agenda. Each of the communities in Southwest London have different needs when we talk about issue around health inequalities and EDI. And we are looking at that in terms of how we support the work that local communities are doing, some of the work that the local boroughs are doing, and then how can we then probably use a Southwest London approach to start pushing the agenda. What I would say is that it's very key on the priority. I will need your support. I will need your help to come forward with ideas. And in terms of if there are other works that you are doing within this area that you like us to showcase or share as best practice around the area, I can put my email address in the chat box. And if you need to have a chat with me in terms of how we can move this agenda forward, please do get in touch with me.
Thanks so much, Gloria. Right, I'm going to go back to a written question. So we've had a question about the Health and Wellbeing Hub for East Merton, which has come from Mitcham Cricket Green Community and Heritage. Mark, I mean, there are a number of different elements to the question, but probably best just to come to you to provide a response covering as much of that as possible.
Okay, thanks for that, Andrew. And just to say in terms of the Mitcham and East Merton Health and Wellbeing Hub, we've now identified potential funding, which allows us to progress and move forward with the hub in Mitcham and the surrounding areas. So the new hub's going to serve people of Mitcham. It's going to offer a range of different services, and it will also connect with local people and signpost them to other services across Merton and beyond. The hub will not just be about a building. We want to make sure that it's about a community. It's about community connection, and it enables people not just to receive treatment, but also to receive advice and support in staying healthy. That said, we've established a programme board, and the programme board actually meets for the first time tomorrow. And what we want to do at that first meeting is really make sure that we're considering how the community is best involved in the plans going forward. We've also done a lot of engagement on this in the past, so we want to make sure that we're listening to what has already been said and included that again in the plans. At the meeting tomorrow, we need to set out the process for an options appraisal. Now, it's really important to emphasise that as part of our due diligence, we need to make sure that we are looking at all the available suitable sites in Mitcham and assessing them accordingly. And some other sites have been put forward to us in Birches Close and also in Sidthorpe Road. But I wanted to just stress that the Wilson is the preferred option for the NHS at the moment, and that is how we are progressing the meeting tomorrow. In terms of then engaging with our communities, that's one of the first things we'll talk about, but we will be publishing both our minutes of the meeting and approved versions of documents on our website as the board agrees it. So tomorrow's first programme board will be really pivotal to starting the new process. Back to you, Andrew.
Thank you, Mark. Really helpful. So Charlotte, back to you for another question from the chat.
So we've had a related question from Bruno and Piers, just about the voluntary sector and community voice within the ICS. So I think Piers is particularly asking, will the meetings be in public, as well as how we listen to community voice? And Bruno, I think you're asking generally about the relationships with local authorities and also the voluntary sector.
So are you going to answer that yourself, Charlotte?
I might do. I might do. So I think so around community voice and the voluntary sector. So we already have lots of really good ways of hearing community voice and patient voice within what we do as a CCG and a health and care partnership. So we're going to be doing some work over the next few weeks, actually, Piers, to come and talk to you and other health and wellbeing board chairs, our community engagement steering group, to talk to you about which structures work both at borough level and at place level and how we want to improve it going forward. So really looking at what do we want to keep and what do we want to build on. And if we look at all of the new NHS England guidance that has come out, voluntary sector voice, Bruno, is really strong in all of that guidance. And at local level, the voluntary sector is already on place leadership groups and it is well connected. But we want to do more to make sure we recognise the voluntary sector and help people understand the great work that the voluntary sector is doing and could do more of. And in fact, we have just won a bid. We bid for some money, £10,000 from the national team to help us sort of facilitate that kind of voluntary sector interaction, both at place and at South West London level. So we've got lots of plans and definitely going to be coming to talk to you about it. Yeah, hopefully that's fairly succinct, Andrew.
Thank you, Charlotte. Yeah, very helpful. Right, I'm going to go back to another written question. I particularly like this one. With the transition of the South West London CCG after only 1 year to the integrated care system in March next year, what do the implications look like for Merton, and will there remain the strong and experienced clinical leaders on the new board, as mentioned in the report, who responded so well to the recovery through COVID? Well, I would agree with that. In answer to that question, Vasa, can I come back to you?
Thank you, Andrew. Yes, you may. Yes. So from a Merton perspective, in Merton, for years, we have had a very functional and a very united and a very well-developed, mature Merton Healthcare Together and a Health and Wellbeing Board. Last night, I attended Health and Wellbeing Board. I looked around me and I was reassured. No one present there last night is leaving Merton. So we are staying for Merton, in Merton. The next thing I think we must remember is that in the ICS board, there will be a voice of Merton Primary Care. There will be a medical director. So there will be clinical presence and clinical leadership at ICS level. And at a personal level, Andrew, people like me who love to be in the engine room have taken up roles at ICS in clinical networks. In my case, not one, but a few. Now, this allows us to be there with the voice of not just Merton, but the voice of South West London patients and also the voice for South West London clinicians. So I don't think there is going to be any cliff edge. I think there are a few more mileage left in me to stay and support.
Well, on a personal level, Vasa, I'm very happy to hear that. So, Charlotte, can I come back to you for another question from the chat?
Yeah, so we might want to take this one from Nick McLean, and he's asking, could we have an update as regards the investment to the Epsom and St Helier hospitals and presumably the new Sutton hospital?
Sure. So Sarah or James, which of you wants to take that question?
Shall I give that one a go?
Yeah.
So yes, we're progressing well. We are working with the trust who are now taking forward the full business case. There's obviously a national process to go through to get that all finalised and signed off. At the moment, some of the costs have increased and they're just working through that as a trust at the moment, and that's due to the fact that we are, because of COVID, increasing the number of critical care beds and looking at how infection prevention control, what additional measures we would want to put in, which we were asked to do as part of the work that we did around IHT. But we are very clear that we are on track at the moment, working with the national team, and we would like to continue to the original timescale, but obviously that's dependent on final Treasury approval. So that's where we are currently in the process.
Thank you, Sarah. So I'm going to go to another written question. There's a theme here because it's a third question from Councillor Gould. The government has committed to reaching net zero carbon by 2050. This means significantly reducing emissions as well as offsetting using carbon capture. The NHS accounts for 5% of the UK's carbon footprint, equivalent to the whole carbon footprint of Cyprus. Noting the above extract from the report, what more could the NHS do now locally to reduce its carbon footprint, considering that the technology for carbon capture on a significant scale is not yet available? So I know we do have a sustainability working group at South West London, but because this question has come from Merton Vassar as the Borough Chair, I might just come back to you again.
Thank you, Andrew. I'm really pleased that this question has been asked because as clinicians, Andrew, we see climate change as a health problem. We know that it's already causing an impact on health, and we know if it continues unchecked, it's going to cause greater impact on people's health. And even if I ever forget climate change as a health problem, my Director of Public Health in Merton, Dagmar, will certainly remind me about it at the very next Health and Wellbeing meeting. So I dare not forget. Now, we have to look at it from the health service point of view, from a commissioning point of view in our contracts, how we recognize carbon efficiency in our plans. As an organization, we have to be responsible in the way we look at our estates. And yes, primary care estates are also part of estates, and we all campaign for estate development, but we have to be aware of the impact of climate. And that is why in our committees now we have a person who specifically looks at, in our borough estate committee, who specifically looks at climate, the impact of climate, and who seeks advice on how we can make our buildings more climate friendly. It's not merely in managerial sense that we can talk about managerial sense about ICS Green Plan and ICS SRO. We can talk about all these documents, but at clinical level too, we don't run away from our responsibility for commitment on this topic of carbon and climate. Now, as an example, I can tell you in our urology network, Ben, the consultant colleague whom I work with, talks about surgical instruments, sustainable use of surgical instruments. We talk about one-stop clinics, which means less travel. We talk about more day case, which means less travel. We talk about greater use of digital telephone consultations where appropriate, less travel. We talk about prevention, early detection, self-care, less travel. Diagnostic hubs, certainly less travel, because you go to one place, get multiple investigations rather than going to 5 places for 5 different investigations. So if you look at our commitment, there's a managerial commitment, but there's also a clinical commitment because we feel that this is a public health problem.
Thank you, Vassar. Really great answer. Right, there is a hand up, so I am going to slightly go out of order and go straight to the hand, which is Daniel Ashcroft. Daniel, do you want to unmute yourself and ask the question?
Yeah, thank you very much, Andrew. Can you hear me? Yeah, bro. Yes. I thought it'd be brave. Thank you for the presentation, everybody. I just wanted to follow up on 2 answers given, if that's okay. First to Mark about the future of the Wilson, and I wondered if there was a time frame in relation to the programme. And secondly, I wanted to ask a bit more about the increased costs for the proposed new hospital in Belmont that Sarah just mentioned. The plans initially were expected to be £511 million, and we noticed a report in the Health Service Journal recently that suggested that the Treasury had asked for the proposals to be around 20% less. but concerns were also raised at the Trust Board meeting and that these costs were rising, and the proposed move of the renal services would be an extra £80 million as well. And so I just wondered if that report was true, if the Treasury had asked for cheaper proposals, and if it was, whether the far cheaper proposal of £400 million to improve St Helier Hospital at its current site had been shared with the Treasury. Thank you.
Thank you for those two questions. So let me come to Mark first.
Okay, thanks for that, Daniel. Daniel, I think that's one of the first questions we're setting out the process tomorrow at the programme board. So what one we will set out the process and also the timeframes and the indicative timeframes and the certain milestones that we have to go through in terms of both funding, design and engagement. So the answer is we will discuss that tomorrow, and then we will certainly publish that when we've issued the papers and the minutes.
Thanks, Mark. And then, Sarah, do you want to answer the question around
Yeah. So I am not aware that anybody has been asked to reduce from the 500 million that the government promised. As far as I'm aware, that still holds true, and that the government's commitment to the 500 million is still there. I do know that the costs are increasing. The longer we go on, costs will increase, but also because we are looking at things like ICU and making sure that the impacts of COVID are reviewed and ensured that we are covered through that. We're working on that now with Epsom St Helier, and they're working with the Treasury and with the national team to make sure that we can get that additional funding to make sure that we can build the new hospital. On the renal, I was going to suggest that James Blythe actually comes back on that one, because he's been working on the renal proposal.
Okay, thanks, Sarah. And probably the final part of the question that Daniel wanted answered was, have we put forward the refurbish, rebuild St Helier Hospital as a standalone? I'm assuming the answer to that is having gone through the consultation and come up with the preferred option. That is not something we're considering.
Sorry, no, I missed that. No, that was never an option that was agreed by the CCG, so that wouldn't be put forward as an option. The option that we are putting forward is for the Specialist Emergency Care Hospital, with 85% of services delivered at the existing local hospitals. So, and that is the model that we all support and think clinically is the right thing for local people. Does James?
Yeah, should we bring James Blythe in on renal?
Yeah, thanks very much. So good morning, everyone. My name's James Blythe. I work for the ICS, and one of my roles is that I've been leading the recent public engagement on the renal programme. So as you'll be no doubt aware, Daniel, the proposal for renal inpatients was that they would move from the St Helier to the Sutton site as part of the Building Your Future Hospitals development. So there was already some funding associated with that move, and then we have secured separate system funding for the remainder of the renal redevelopment which is proposed. Now this reflects the fact that this is not a programme that just affects Epsom and St Helier. It also of course affects St George's, and it reflects the fact that the programme is also aiming to address long-standing estate challenges at St George's around renal care, and also helps to address some challenges around the clinical model and to improve the clinical model as well. So I think that it's although there's a link into the Epsom and St Helier capital, it's also a separate standalone programme, and that's why we've done a separate standalone piece of engagement.
Thanks, James. I'm going to take one final question from the chat because we're due to finish at 1:45. And just to give everyone a fair chance, let's take one more question from the chat. Charlotte.
So probably the final one. So from Jamie Gillespie for James Murray, I'm asking how far can he plan ahead, and is there an agreed budget for 2022-23?
Right, thank you for that. So as you're aware, we've kind of been working on the sort of emergency type scenarios, and budgets have been set for basically 6 months at a time. So we've just found out what our budget is for the second half of this year. My expectation is nationally they're working through, the NHS is working through the comprehensive spending review with the government, and there is a commitment from the national finance team for the NHS to give us a much clearer indication of what our budgets will be over the next 2 to 3, 4 years. So I am anticipating over the autumn we'll get a much clearer idea of the budget that we have for not just yet next year, but some indications for the year after. I think that will be structured in a way that, as you've heard from the conversation, supports things like vaccinations and the continuation of that, supports a lot of the recovery type areas, not just around elective, but around mental health and other areas. But it will also recognise the need for us to get back to business as normal. So there'll be some multiple challenges and opportunities in there. So hopefully we'll get that clarity over the coming autumn months.
Thank you, James. So we need to draw to a close. I'm going to finish by thanking people. So I really want to thank everyone who has presented today, but more importantly, thank those people who have supported the meeting in getting things ready and making the meeting work effectively. So real thank you to everyone who has worked on the AGM. Thank you to the attendees for coming, and thank you for some really good questions. More than that, though, I just want to put on record our thanks as a CCG governing body and as a leadership team for all the people in the CCG who have worked incredibly hard over the last year in really challenging circumstances, and most of the time having to work remotely with the isolation that comes from that, with a huge amount of pressure. So thank you to everyone for everything you've done. And I guess also thank you to everyone that we've worked with in the system. So all our health partners, but all our other partners that we've worked with, such as local authorities, the voluntary sector. It's been a massive system effort that we have put in this last year to combat the pandemic, and I just think we've done remarkably well. So thank you to everyone, because I've seen everyone go way above and beyond what is required, and we just need to acknowledge that. So thank you, and I shall draw the meeting to a close.